Okay, welcome everybody. Okay, welcome everybody. Welcome everybody to the hand session. I present my co-president, Ilse de Greve from Leuven. And me, I am Bernard Lefebvre from Charleroi. The first presentation is Farhat Hussein. We talk about the why conservative treatment for the fracture of the wrists.
So, good morning, everyone. I will talk about the conservative treatment in distal radius fracture, why we do it, and when we should do it. So, the goal of treatment in distal radius fracture is a wrist that provide pain-free of motion and stability to permit activity of daily living and vocational activities in all age groups, and to prevent degenerative changes, especially in the young population. So 70% of distal radius fracture are still managed non-operatively. The indication for non-operative treatment are stable undisplaced fracture or displaced fractures that become stable after reduction. So the factors that we should take into consideration in the treatment of distal radius fracture are the presence or absence of intra-articular involvement, the degree of comminution, the dorsal or volar displacement, the involvement of distal radio-ulnar joint, which is a very important point, and the carpal alignment. So the indication for close treatment are low energy fracture, low demand patient, patient with medical comorbidities, and fracture with minimal displacement and acceptable alignment. When we are thinking, in fact, of conservative treatment, we should always think of distal radio-ulnar joint congruity. And the measurements that we should take into consideration are, first of all, the palmar tilt. So usually the palmar tilt is about 10 degrees. If we have a dorsal angulation of less than 5 degrees or less than 20 degrees in comparison to the contralateral distal radius, we can accept a conservative treatment. The second point is the radial inclination. We should have a radial inclination of more than 15 degrees to accept conservative treatment. The third point, the third measurement, is the ulnar variance, which is a very important measurement. In fact, a change in an increase of 1 millimeter in the ulnar variance will increase the mechanical load through the ulna by more than 25%. That's why it's a very important factor in the stability of the distal radius fracture. The fourth measurement is the radial length. We should have a radial shortening of less than 5 millimeters to accept a conservative treatment. And the carpal alignment. In fact, if we have a carpal malalignment after closed reduction, the conservative treatment is contraindicated. How we can do the diagnosis of carpal malalignment? On the lateral view, we draw two lines. One line along the long axis of the capitate and another line along the long axis of the radius. If these two lines intersect within the carpus, then we have a carpal alignment. If they intersect outside the carpus, then we have a carpal malalignment, and we should not accept conservative treatment. So if we have these factors, Lafontaine predictors of instability, if we have these factors, we have a higher chance of failure of our conservative treatment. The most important factor that predict an instability is the radial shortening, followed by the dorsal comminution. So the dorsal comminution is more important than the palmar comminution or the intra-articular comminution. If we have the other factors, if we have more than 20 degrees of dorsal tilt, if we have an initial displacement of more than 1 centimeter, if we have severe osteoporosis or associated ulnar fracture, all these factors are predictors of instability. So the conservative treatment, the most satisfied patient with conservative treatment in terms of grip strength and risk arc of motion are the patients age of 60 years and older. In fact, a study was done in 2019 and it was published in the Journal of Hand Surgery. It was the largest clinical trial ever conducted in hand surgery. They studied the relationship between functional outcomes and patient satisfaction after conservative treatment of distal radius fracture. They do the comparison with the uninjured wrist, and they concluded that the older patient, after 3 months of conservative treatment, they were satisfied upon recovering 59% of grip strength and 79% of wrist arc of motion. And at 12 months after conservative treatment, we have a recovery of the grip strength by 82%, and the mean arc of motion is 88% of normal. Unfortunately, with the conservative treatment, we also have some complications, like failure or loss of reduction, especially if we have 3 or more of the Lafontaine criteria of instability. We should also pay attention to the carpal tunnel syndrome and avoid the position in extreme flexion and ulnar deviation. And we can also have extensor polystrongus rupture. Thank you.
Thank you, Hussein. We have 2 minutes for discussion, so maybe you can come back. Any questions from the audience? No immediate questions. I have one question.
Yeah.
So failure of reduction is one of the risks of conservative treatment. If there is no reduction necessary, that means there is no displacement, then of course conservative treatment would be a preferable option in many patients. Do you think that secondary displacement is possible and without a new trauma, of course? And would there be any place for bracing instead of plastering so that motion can be started early on?
So, yes, even if there is no displacement on the initial radiograph, we can also have a displacement. That's why we should do radiologic control at 1 week, at 3 weeks. So yes, even if we don't have displacement, we can have this displacement, yes. And the second question, it was?
I understand, have to push this button really hard. I understand that you do fear secondary displacement. You agree with that, Bernard? And then my second question is useless because that means we need plaster and early active motion is not allowed.
Yes,
right?
yes.
Okay. No more questions or remarks? Thank you. Jongens toch. I don't need to continue to push this, only once. So, first I want to apologize Frederik Verstreken for not being here. He's probably attracted the most popular virus of today. And then second, I would like to present our next and invite our next speaker, Emmanuel van Hoeken from UZ Leuven and Knokke, who is going to talk about the place of pin surgery. Manu, if you want, you can take the mask off.
Okay.
It's your choice.
That's better. We only have 5 minutes, so I will act as a defense lawyer for an old technique that most of you will probably know, and that's the distal radius spinning for distal radius fractures. I press here. So our defendant was born in 1976. His technique that was invented by Kapanji is a pinning technique that most of you have known. Maybe the younger residents may be less familiar with. It's an easy technique. It's an easier technique, and it will normally be not that difficult to teach and to learn. This was revised in 1987 with a set of standard guidelines also by Kapanji, for which I have the old paper presented for you in a second. You will hear some talk that this technique might be outdated. Of course, there's an advancement in materials and the plating, so you will see that the pinning will get more and more obsolete. Well, I am here to convince you not that the pinning is the ideal technique, but more that the pinning can be used in, as some alternative to the plating if necessary in selected cases. Indications for the spinning were strictly set by Kapanji himself for dorsal angulated fracture, extra-articular or an easy intra-articular fragment. For complex fracture, this does not yield any satisfactory results. Also, we have to note that there's still a possibility for closed reduction in patients with monoblock fracture. There were some surprising things in the publication of Kapanji, which I will show you. He used, for example, in the 87 publication, threaded wires. He did not use any plaster, which we still use today, of course. He didn't advocate a percutaneous use, which I've seen many residents do, that they just puncture the skin and then try to reduce the fracture, while actually quite a significant incision was advocated. And he did not use a motor. I will not go into the interesting case of hospital management in this time for the 5 minutes. As you see, there were 3 days of hospitalization, and those was, of course, different times than we see today. In literature, we can see a 2015 study that showed some significant differences between the plating and the pinning. What we see is in the short term that there were that the patients did better with the plating. After 1 year, there was a minimal difference noted. This was confirmed in a 2018 study that also confirmed these findings with 14 different publications. What was interesting is what we see here is that an unacceptable reduction and loss of reduction increases, the chance increases with age. So what we see coming back is that if the next studies will be conducted also what they call elderly patients, patients over 60, which I don't really consider elderly, but okay. They say over 60, and this is a study in 2020 that had over 2,190 patients, which saw that a precise restoration was not associated with better patient outcomes. So even if we see some loss of reduction with the pinning, it is discussed if this is really that big of a difference for general outcome. My closing statement, to keep in my 5 minutes, I would say that the K-wire is not, I cannot advocate it as the same technique for plating. What I do think is that the K-wire should be reserved for selected cases in elderly patients, for example, with comorbidities, in which age is not really the main factor, but more the comorbidity, the fragility of the patients, and you should see it as an alternative when plating is for some reason not possible. It will diminish in usage, and I have heard several residents who have not seen it yet in their entire training. So I would still suggest to keep it in your head, in your tool kit, as a surgeon for cases which you cannot solve otherwise. And also, please do not forget to remove the pins, because this gives some complications. This is a patient from half a year ago, no, from in October at least, and the pins were inserted in 2009, and he had an EPL rupture, which he sought a second opinion for. So please remove the pins. I thank you.
Oh, sorry. Yeah, thank you very much. Do you have a question on the floor? Yeah, Evra.
What will be your final statement? What is the proportion that you think is still reasonable?
I do not advocate a reasonable proportion. I advocate to have it as a technique, to be trained in the technique, to have it in your head in case that the plating is not possible.
So you favor the plating?
I personally favor the plate, yes, but I'm here to defend the pinning. So the point I'm trying to make is to illustrate that the technique is not obsolete, is less and less in frequency, but that is not obsolete and should be taught in training to the younger residents, and that we should always have it as an option in some rare case that we cannot do the plating.
And by the way, don't speak of elderly patients, but of experienced patients.
I will keep that in mind. Very rarely. Only in children, for example, but rarely as the first choice. Maybe if we can, if there is some reason why you cannot do a volar approach, if there is a reason why the patient cannot be sedated for a long time, then I would opt for this type of technique.
Okay, thank you very much. No question more? No? Okay, thank you.
Thank you.
The next speaker is Ilse. We talk about external fixator surgery.
So, thank you. Why use external fixator surgery? I have no conflicts of interest, and I'm not an advocate to any technique. Is it a... Yes. So let's have a look at the history, at the indications, at the technique, and at the discussion of how, but also when to use external fixation in distal radial fractures. I do admit that it is tempting, if we see a fracture like this, to consider external fixator to probably to a lot of people present here or looking online today. It was first introduced in between the two world wars for children by Ombredan to have a temporary osteosynthesis. But today we have a bimodal age distribution where on one side we have the young people, young patients with a high energy trauma, and on the other side of the spectrum we have the more experienced patient with a low energy trauma and probably osteoporosis going together with this experience. So classically, the wrist-spanning external fixator is the most common technique used in highly comminuted distal radius fractures that are believed to be unstable, and that open reduction and internal fixation in those cases is probably not an option. The idea is to regain length and alignment by distraction and so-called ligamentotaxis, although we all know that in terrible traumas the ligaments are probably torn as well. The problem is that the complication rate is pretty high, up to 62%, where we mostly see problems that are known to external fixators, loose pins, pin tract infection, but also a serious discomfort, malreduction, and if it was reduced, a loss of this reduction. And secondary to this severe attempts to gain reduction, these vicious positionings, as you see in these X-rays, to attempt these reductions, give you stiffness and the most feared complication, CRPS. There are alternatives to this external classical radio metacarpal external fixator, as the internal fixator used as a distractor, the non-bridging external fixator, and even the dynamic external fixator to attempt some motion or secondary correction. Technically, the idea is to reduce the fracture and then put the external fixator on, and if needed, the former technique, pins for instance, can be added to augment the reduction and the fixation. Either parallel or converging pins can be used, and we have to be very careful for the dorsal radial cutaneous nerves by careful dissection, spreading, and a protecting trocar. The best position is central to the diaphysis. Avoid eccentric placement, because then you must certainly need to fear loosening. In children, avoid growth plates. Allow for ideal motion of the fingers. A good idea is to bend the index so that the extensor is out of the way, to put the pins in a 40 degrees position in the second metacarpal. That's the classical positioning. And of course in the forearm you go between the extensors of the wrist and the extensors of the fingers. So what is the state of the art? Well, right before our corona crisis, Rongier had the expression that the external fixator should not be used anymore. Perhaps that's a little too extreme, but a lot of studies do confirm that we need to be careful in decision making and considering this external fixator, because the results compared to other techniques are not better. The best results are seen with augmented osteosynthesis, for instance, plates or pins in complex high energy trauma. It is used as a protection for articular fractures, but we need to be careful to count on ligamentotaxis, because, as we will see in the next slide, CRPS is the worst enemy in overdistraction. There are other techniques, and we need to find the place of this, because the non-bridging fixators are introduced to have early motion, but up until now the superior outcome has not been proven yet. Of course, if we look at comparing meta-analysis studies, we see that you have a lower dash, better radial length restoration, and lower infraction rate in open reduction and internal plate fixation. Of course, they only need to be removed in 24%, and I do not believe that an external fixator will stay on as this last patient with 12 years of pins, so 100% removal is necessary. This is a study that does show that over-distraction is dangerous, digital motion is lost, force and function are worse, and pain is increased. CRPS is to be feared. The attempts of improving this stiffness of the wrists by dynamic external fixators and also by non-bridging ones have not yet proven successful. And at this moment we know that the best guarantee is to reconstruct motion is to achieve perfect reduction. And what we need, as we have seen in the first presentation, is no shortening, no dorsal tilt, no incongruity. And as in the first patient I showed in the first slide, this was not achieved. It was a patient that came from abroad with 2 wrist fractures. So even though it still looks challenging, this does probably have a better prognosis. The complication in stage treatment can be an option, is often chosen for, but a short period in between secondary surgery is needed, and we have to avoid overlap of the pin tract surgery and avoid dorsal approach, certainly in compromised patients. The indications can be open fracture, soft tissue trauma, neurotrauma, radial artery repair, and certainly implants, polytrauma, and the inability to maintain reduction in a splint. So in conclusion, it is only used in cumulative fracture, and then preferably with other material within the framework of the principle of damage control, but neutral position and no over-distraction. Can be considered in arthroscopic techniques, but today we have the instrumented surgical positioning, for instance, with the Trimano. Again, I have no conflicts of interest. So always consider internal plate distraction if you really do feel that distraction is needed. These are some references. Thank you.
Thank you very much, Ilse, for the beautiful presentation.
Yeah, well, if it's 2 stages, as short as possible, 9 days. If you really need it, but you have a good internal fixation that you can count on, you can take it off probably less than 6 weeks. But if you only count on an external fixator, 6 weeks will not be sufficient. Okay. Because you will have secondary displacement after removal, so you probably need it 10 weeks or so.
Okay, thank you. Thank you very much.
What do you think about the use of external fixation in open fractures?
So the question is what I think about the use of external fixators in open fractures. And I do think that sometimes it was one of the indications at the final slide that soft tissue injury does necessitate external fixation. But hopefully, if the soft tissues allow, you can, within 9 days, turn it to another technique. Agree, Xavier? Thank you.
Okay. And now Jeroen van Ack from Kortrijk. We talk about the palmar plating of the distal radius fracture.
Good morning, or maybe already good afternoon. I'm Dr. Van Haak, so I will present to you the palmar plating of distal radius fractures. I just have to see which button that I have to push here. Yeah, okay. So, as you already heard, it evolves our treatment, and you have already seen different methods. And the goal of operative treatment is to obtain anatomical reduction of and a stable fixation to permit early mobilization of the wrist without loss of reduction, and a cast-free after treatment, so to have a fast revalidation. So the principles, biomechanics, I'll better explain it to you with this slide. You see on the yellow one is the fracture dorsally displaced. In this computer-generated model, we remove the ulna, so you're looking from the side, from the ulnar side, and you see the impaction, and you want to neutralize your impaction from the dorsal side after the reduction. Else you have a big gap that will again fall in when you remove your material, or if you don't have a stable fixation. So the principle of the palmar plating, fixed angle. You see then for the orthopedic surgeons between us the dynamic hip screw, because from the pegs or screws dorsally the force is translated to the plate, to the shaft. So the whole piece that you have there on the dorsal side is unloaded. That is the principle. So I have to push quite hard on this button also. Indications, everybody should know them because it's the indication for every treatment almost. More than 20 degrees dorsal angulation, impaction of more than 5 millimeters, a radius shortening more than 3 millimeters, and translation. And we have to also say intra-articular displacement between fragments of more than 2 millimeters, open reduction and internal fixation is indicated. And I have to go back, I'm sorry. Okay, and because low bone density is a predictor of secondary displacement, the indication for operative treatment is higher in the osteoporotic group or the elderly group. This is for you to decide what's elderly. So, one example, the young male patient, and you see I do a reduction with K-wires, the Capenji way. I could stop there, but why stop when I could make it even better, my reduction, and even more stable? Classic approach described by Orbe. And you can see that my incision goes a bit more distally than the wrist crease, so that I have a nice exposure of my lunate fossa, of the ulnar side of the radius. You see then on the right slide, on the right picture, that my plate is standing a bit off the shaft, just to put a little bit more palmar tilt when I put the plate nicely to the shaft, and then I have my perfect stable reduction. So this patient could directly, that means after the pain is settled, start his rehabilitation. But most of the time we have our old patient. So you have the old patient is more osteoporotic, like in this old lady. And again, you see on step 1 my pins. And here I know if I just treat it with pins, after 6 weeks I remove the pins and everything will crumble down again to the angulation, dorsal angulation. With the plate, I get an angle stable fixation. I could discuss all the pictures, but I'll let you that at home when you review the talk. So the contraindications are also there, and that is the main topic of the 5 minutes that I have for this, because everybody thinks palmar plating is for every fracture. No, it's not for every fracture, just for the right indications. So you have to think about your contraindications. You know the general contraindications, but more important is the fracture-related contraindications, the bone quality and your fracture pattern. Clear dorsal fracture patterns, or like in dorsal Barton fractures, maybe you just would go to the dorsal side instead of the palmar side. Radiocarpal fractures, dislocations. You can do this maybe with a palmar plate, but that is not an option here. Then also isolated radial styloid fractures, you can maybe, but maybe you choose a styloid plate or a pin. And then small avulsions fractures of the volar rim, the nice small bit that you have just here, ulnar side, is a main stabilizer. This you don't take with a palmar plate, you do this with fragment-specific material. And then dorsal impacted articular fractures with an intact or non-displaced volar cortex maybe also go better the dorsal way. So these are 5 contraindications, and like also this one, there's a trend to abandon palmar plating. I've done such a fracture with the palmar plate, but you have to be aware because these fractures have a higher risk of avascular necrosis of the distal fragment, and seldomly you get intact, like perfect anatomical reduction. So here you have to think bridging plate, external fixation. So as a conclusion, predictable results with a plate if you have the right indication and a good surgical technique, because most of the errors are made in your good surgical technique. The method has shown in the literature good early results, better than most other treatments, but in long term, no significant difference. But here we can endlessly discuss. I think that we have a bias in our literature, because you have, like I stated, badly reduced distal radius fractures stabilized with spins compared with badly reduced palmar plated ones. So you have to be very critical about literature. So the complication rates are similar, but the volar rocking plates is really, I guess, the main choice and the best option and the right indication for osteoporotic fractures. I thank you.
Thank you, Jeroen. Any questions from the audience? We all turn to volar plating. Yes, you have a question.
You said in a healthy patient, you can start vocalization as soon as the pain goes away. What time is that? How long?
Like in our institution, classically, we put on a little cast, a splint for pain reasons for a week, and then they can mobilize. But in my early days, when I was young and I wanted to make a statement to my elderly or more experienced colleagues, like I said, I let them use day 2, like the next day. But that gave maybe too much pain, so a week I found acceptable. And I also think in some high energy ones, young patients again, sometimes a bit longer, 4 weeks, to also let ligaments heal that maybe have to heal that we like underestimate.
Thank you. Another question? I have one small question, Jeroen. What do you think about arthroscopy? Do you associate arthroscopy a lot of times?
Arthroscopy, I don't do a lot of time directly in my radius fractures, because when I use a mini fluoroscopy, I know in most of the times intra-articular I have like perfect reduction. And in some indication when I think, hey, maybe the ligaments could be hurt here, I always do it. So in a specific fracture pattern, I go in, I look not for my reduction mostly, but for my ligaments. Reduction arthroscopically is sometimes difficult, and sometimes it gives you extra time that in fact you don't need. So it could be like, it's more the ligament that I want to control instead of my fracture patterns.
Which you then also would stabilize carefully.
Yeah, or change my attitude post-operatively.
Ah, okay. Thank you. Thank you, Jeroen. Okay, since there are no more questions, we go to the next speaker, which is the president of the Belgian Hand Group, Anne Lejeune, who is going to give us a talk on complications, I think, in plate osteosynthesis of the distal radius fractures. Complications to avoid. Go ahead.
So, complication of volar plating of distal radius fracture, I have no disclosure. 15% is the overall rate complication of the volar locking plate, with 10% of minor complication and 5% of major complication, with requiring secondary surgery. The watershed line is the distal ridge of the radius. The risk of rupture of the FPL depends on the plate placement, not distal to the watershed line, where the FPL is most vulnerable. The 3D models could help us to reduce the incidence of a dorsal screw penetration and the risk of rupture of the extensor tendon. The screws must be short, unicortical, and 75% of the depth is enough for the stability of the reduction. Dorsal tangential view in fluoroscopy is also useful. Here is a case of Dr. Delpinal with intra-articular screw. You see the help of the arthroscopy. There is a cartilage wear on the lunate due to the intra-articular screw, and the reduction is incorrect. The lunate facet fracture. So you see the volar locking plate seems well done, but at the 3rd week, you see a redisplacement of the fracture. There is a failure of to capture the lunate facet rim. So the volar locking plate is not a panacea. All the fracture cannot be treated, but a volar locking plate. In 2013, Gregory Bain published the fundamental concept of the osteoligamentous unit of the intra-articular fracture. The fragment of the fracture are still attached to the ligament, and so here, with the lunate facet, you have here the short radiolunate ligament still attached, which can explain the volar luxation of the carpus and the lunate. So this kind of fracture has to be treated by specific fragment plate, by specific screw, or even when hook plate, or even tension band. This is the CT classification of intriguers based on the osteoligamentous unit or the key fragments. You see that the lunate can luxate in different directions, in volar direction with the short radiolunate ligament, or in dorsal with the radiotriquetral ligament. So here, a dorsal ulnar corner. So you see that the reduction with a volar locking plate is not perfect. There is a step, an interarticular step, and also there is a dorsal carpal luxation. So with an intact volar cortical, you have to choose another way, another approach. And so here, a dorsal approach should be better. So there is some contraindication to the volar locking plate, as said Jeroen, the Barton's fracture, the lunate facet, the dorsal articular comminution with intact and non-displaced volar cortex, the dorsal ulnar key fragment, the die punch fragments with dorsal rim and non-displaced volar cortex, massive intraarticular comminutive or bone loss, and some association with carpal lesion. Here's some example. The die punch, you see the volar cortex is intact. The Barton's fracture, volar cortex intact. The dorso-ulnar key fragment, with a volar cortex fractured, but it's still stable. And the lunate facet. For the Professor Hahnemann of Maastricht, there is 35% of volar approach, 28% of dorsal approach, and 33% of combined approach. So take-home message, 5% of complication, 15% of complication, 5% of major complication. Some fracture cannot be solved from volar. Use the CT classification of Intringer, think key fragment, osteoligamentous fragments, and go for it. Look at the lunate on the sagittal view and detect any subluxation. Be familiar with the dorsal approach, but always with a good volar cortical or a double approach, and always the volar first. So we have the volar locking plate, but we have also the volar rim plates and the specific fragment plates. For complex fracture, combine all the plates. And finally, look inside the joint with dry arthroscopy or nano-arthroscopy. Thank you very much.
Thank you, Juan. I have a question. No. The complications are all days technical complication, no? For the plating.
It's often the indication of the plate.
Yeah.
Normally we have 90% of volar approach and 5% of dorsal approach. But I think that we have to think more about the different options and think to use more specifically the dorsal approach. When you see that the key fragment is dorsally, when you have a palmar cortex intact, we cannot use this approach.
Okay.
We have one question of Lori Kegels. She doesn't often use combined dorsal and volar approach. Is there a specific fracture she should think about to use this method?
Yes, when you have a massive comminutive fracture, you begin with the volar approach, you fix the volar cortical, and after you can try to reduce the dorsal. Mm-hmm. But first, the volar.
Mm-hmm. I have one small question on. I always advise my patients to consider plate removal because we sometimes see in the long term, even after 20 years, when they are very, very experienced, that they get flexor tendon ruptures, and then it's their decision. What is your approach to this?
In our team, we remove all the plates. In the literature, there is only 6% of removal of the plates, but in our team, to avoid any complication with the flexor tendon after a few years, we remove all the plates between the 6 and the 12 months.
And the removal is after how many days or month? 3 months?
6.
More? 6?
Between 6 and 12.
Okay.
Thank you.
Thank you, Anne. And for the conclude the session, the guideline of the fracture of the wrist is presented by Olivier Barbier.
Hello. Following all that has just been said, we have for you in the next 10 minutes guidelines for the management of distal radius fractures. Medicine, based on data from which evidence of the best treatment emerges, is a science. However, despite the large number of studies carried out on distal radius fractures, there is little evidence, in particular because the best treatment proposals can vary greatly depending on the patient group you treated. Medical science then becomes an art. The art of providing the right treatment for each individual patient. Here are some guidelines for working toward this goal. The first phase of management will aim to assess the fracture pattern and the patient. The fracture is assessed by X-rays. They will be performed in anterior, posterior, lateral, and oblique ways. Supplemented by CT scan if it seems that this will allow a better understanding of an intra-articular fracture. The graph shows the incidence of distal radius fracture in relation to the age. All those patients can very schematically be divided in two groups. A group A of young patients under usually 55, 60 years old with high functional demands, and a group of older patients with limited functional demands. It's a medical art to understand the physiological state of each patient and their actual functional needs because there is a large intersection between the two groups. The second step of the management will aim to define the objectives of the treatment. For the patients of group A, the functional capacity is strongly correlated with anatomy. Then you will not accept deformity with more than 10 degrees of dorsal tilt, 2 millimeters of articular displacement, or 3 millimeters of radial shortening. For patients in group B, precise anatomy is less important, and the aim is above all to keep the alignment of the carpal bone in relation to the radius without too great dorsal tilt and shortening of the radius to avoid an ulnocarpal conflict. The third step will define the treatment according to a different algorithm for the two groups. In group A, cast immobilization may be sufficient for non-displaced fractures or for reduced and stable fractures. Fractures with significant damage at the level of the joint or when reduction is impossible to be maintained by external maneuvers will be operated on. For group B, surgery is considered if no sufficient anatomy of the distal radius is restored even after reduction. The fourth step will consist in applying the treatment. Reduction by traction via Chinese finger traps or manipulation under analgesia and with radiological control. Thereafter, a cast is applied without extreme position, but with three contact points in the cast to avoid a new displacement. Mobilization of the fingers and elevation of the limb is encouraged to avoid swelling and limitation of mobility thereafter. When surgery is required to reduce and stabilize the distal fracture, osteosynthesis is currently performed in most cases by a volar locking plate. This technique has few complications and shows in the different series results among the best in the different forms of fractures. Alternatives to volar plates exist in specific situations. We reserve the direct pinning of the fragments for extra-articular and non-comminuted fractures. It's a technique which does not require an important equipment and which has a limited cost. Temporary fixation of the wrist is useful in important comminutions by internal fixation with a plate or external device, particularly when there is severe soft tissue damage. The stabilization of focal intra-articular impactions or marginal lesions can be achieved by plates dedicated to specific fragments. However, in the series, they showed more complications by fibrosis following extensive approaches or by tendon frictions than the anterior plates, without a superior functional result. Once the treatment is carried out, comes the fifth step of controlling the reduction and the absence of protrusion of screws in the joints or the back of the radius by wrist mobilization and by radioscopies tangent to the articular surfaces or the posterior aspect of the radius. Arthroscopy can be useful to refine joint reduction. However, studies have not yet demonstrated its benefits for clinical results. Arthroscopy also makes it possible to visualize the numerous ligament injuries associated with fractures, without the indication for additional treatment being clearly defined. What about associated lesions? The need to treat the associated ligament injuries is unclear, except perhaps in the case of radiological destabilization of the carpus by scapholinate dissociation. Fractures of the carpal bones are treated as usual. The median nerve will be decompressed at the level of the carpal tunnel in the event of persistent pathology beyond a simple contusion. For the distal radial nerve joint, this joint will be tested after stabilization of the radius. If instability persists in group A, then surgery for ligament reinsertion or ulnar synthesis will be frequently performed. Conservative treatment will be favored in group B with excellent results in the literature. For the postoperative care, early mobilization by the patient is encouraged. Care by the physiotherapist shows especially a benefit in the event of complications like complex regional pain syndrome. The fracture of the radius can be witness to the risk of fall and osteoporosis. Preventive measures will be taken. The removal of the implant is, in our clinic, systematic, but should be considered usually after 9 to 12 months if they can be a source of conflict, particularly with tendons. These were our proposals to provide the right treatment for each particular patient. Thank you.
Thank you very much, Olivier. It's very clear. Do you have a question? Yeah.
Thank you, Olivier, for this beautiful presentation. It's a remark considering your graphic. Maybe it will be interesting not to do two categories, because from till 60 and then from 60 to the older. I think maybe it will be interesting to make a B category with active person, maybe over 60 also. They will need also anatomic reduction. What do you think about that?
Yes, certainly. At the beginning of my presentation, I showed the two groups, and I said that there is a clear overlap of the two groups. And the art of medicine to see which patient is in which category, because there are older patients with important functional...
On the microphone, please.
And then, yes, There are older patients with important functional demands, and then I think it's the art of the doctor to see which categories represent the best the patient. But I agree that there is a clear overlap of the two groups.
May I ask just another question? Just a remark also, considering the use of implants, nobody talks about centromedullary pinning. Sometime we use, I'm pediatric, so we use it. Sometime for the third distal of a radial fracture. It's not always easy, but what's your opinion about this, maybe to the floor?
I never use that, but I have seen in the literature that it's also a good option. But I present what we really do in our clinic.
Thank you.
I agree. I think to my knowledge, it is very useful in pediatric, and that's what we did mention. But on the other hand, I don't know if the scientific evidence today on all implants is in favor or defines the position of intramedullary fixation yet in adults. Any other opinion? Any other questions on? We finished. Okay, so to the sake of time, I think we have gained a little time that we lost before, and we will end this session now. Philippe, do you have anything to add? No? And we go for a lunch break, or was there a video? Or okay, no reaction. Okay, thank you all.